If you take Metformin, Glipizide, Januvia, or insulin for your type 2 diabetes, your 10-minute doctor visit could not possibly cover everything you need to know. Millions of seniors over 60 take these 4 medications every single day, but 8 out of 10 are quietly draining a vital vitamin from their body, and their doctor never mentioned it. In the next 20 minutes, I will show you the 7 hidden effects these diabetes pills have on your body after 60, the 1 supplement your doctor forgot to prescribe with them, and 3 warning signs that mean it's time to call your doctor immediately. I want you to hear this first. If you're taking Metformin or Glipizide or Januvia or insulin, your A1C number is only part of the picture. It's a big part, but it isn't the whole story. And the piece that's missing is the piece almost no one has time to explain in a 15-minute appointment. Here's what a lot of you are living with. You take your pill in the morning with breakfast. You take another one at dinner. Maybe you inject before bed. Your fingertips are calloused from checking. Your kitchen drawer has 3 glucose meters, 2 of them expired. And still, some mornings you wake up shaky. Some afternoons your legs feel heavy. Some nights your feet tingle and you tell yourself, well, this is just diabetes. It's completely reasonable to wonder about all of this. Most people over 60 on these medications wonder the same thing. Am I on the right one? Am I on too much? Is there something my doctor isn't telling me? Not because they don't care, but because the appointment ended before the real question came up. Picture someone I'll call Ruth. She's illustrative, a composite of common cases, not one specific person. Ruth is 71, a retired second-grade teacher, still babysits her grandchildren on Wednesdays. She's been on Glipizide and Metformin for 6 years. Her A1C runs a steady 6.8. Her doctor is pleased. And Ruth, she's exhausted. She feels foggy by 2 p.m. She's had 2 low blood sugar episodes in the past month, both while alone. She hasn't mentioned either one, because the numbers look fine. That gap between what the number says and what the person feels is where today's video lives. I'm Dr. Eliza Wright. On this channel, I review published research on senior health, what a rushed appointment doesn't have time to explain. I'm not treating you. I'm reading the studies with you. Before we go further, do me a favor. Drop 2 things in the comments. Your age and the city or state you're watching from. I read every comment on this channel. It genuinely changes how I record these videos. Take 5 seconds, drop it below. I'll wait. Now let's talk about what these 4 medications actually do inside your body. Because once you understand the mechanism, every question you have about side effects, timing, and dosage starts to make sense. Metformin. This is the most prescribed diabetes medication in the world. According to the American Diabetes Association's 2023 Standards of Care, it's still the first-line therapy for most adults with type 2 diabetes. Here's how it works. Think of your liver like a bakery that keeps producing bread all day, even when nobody's ordering. In type 2 diabetes, the liver overproduces sugar. Metformin tells the bakery to slow down. It also helps your muscles listen to insulin again. But here's the problem. Metformin has a quiet side effect that a 2020 review in the Annals of Internal Medicine flagged clearly. Long-term use, often defined as 4 years or more, can lower your vitamin B12, and low B12 looks a lot like getting older, tingling in the feet, memory fog, fatigue, balance issues. Ask your doctor whether a B12 level is worth checking, especially if you've been on Metformin for several years. Glipizide. This one's in a family called sulfonylureas. Think of your pancreas like a light switch. Glipizide flips the switch to on and squeezes more insulin out. That drops your blood sugar. It works. It's inexpensive, and it's been around for decades. But here's where it gets interesting for anyone over 65. The American Geriatric Society publishes something called the Beers Criteria. It's a list of medications that need extra caution in older adults. In the 2023 update, sulfonylureas like glipizide made the list. Not because they're dangerous for everyone, because in adults over 65, they carry a higher risk of low blood sugar. And low blood sugar in a senior can look like confusion, a fall, or a trip to the emergency room. That doesn't mean glipizide is wrong for you. It means it's a conversation. Ask your doctor whether your current dose still fits your kidney function, your appetite, and your daily routine. Januvia. The generic name is sitagliptin. It belongs to a class called DPP-4 inhibitors. Here's the analogy I want you to hold on to. Your gut produces a hormone called GLP-1 every time you eat. GLP-1 tells your pancreas to release insulin, but only when your blood sugar is actually rising. It's smart. The problem is, your body breaks GLP-1 down quickly. Januvia blocks the enzyme that breaks it down. So GLP-1 sticks around longer. Insulin release becomes better timed. Because Januvia only nudges insulin when sugar's actually elevated, it's less likely to cause low blood sugar on its own. That's one reason it's often chosen for older adults. A 2018 review in Diabetes, Obesity, and Metabolism looked at DPP-4 inhibitors in patients over 65 and found a generally favorable safety profile. Still, it's not free of trade-offs. Some patients report joint pain. Rarely, pancreatitis has been reported. If you develop severe belly pain that won't quit, that's an urgent call, not a next appointment call. Insulin. This is the one people fear most, and I want to reframe that. Insulin isn't failure. Insulin is a tool. Your body made it beautifully for decades. When the pancreas can't keep up, replacing what your body used to make on its own isn't defeat. It's biology. But insulin needs respect. The dose that worked for you at 62 may not be the right dose at 72. Kidney function shifts, appetite shifts, muscle mass shifts. A 2019 consensus report from the American Diabetes Association and the European Association for the Study of Diabetes recommended what they called de-intensification, a careful review of whether older adults are on more insulin than they now need. That word, de-intensification, is worth writing down. It's the question almost no one asks out loud. Now, here's the piece I really want you to hear. Your A1C is an average. It's a 3-month blood sugar average. And an average can hide two very different stories. One person cruises at a steady 130 all day. Another swings from 60 in the morning to 250 after lunch and back down to 90 at bedtime. Same A1C. Very different bodies. Very different risks. That's why more doctors are talking about something called time in range. Ask your doctor whether a continuous glucose monitor, even for 2 weeks, could show you what your average isn't showing. So what do you actually do with all this? Here are 5 steps you can bring to your next appointment. Number 3 is the one that surprises people. And number 1 is the one almost nobody's talking about. Step 1. Ask about your vitamin B12 level, especially if you've been on metformin longer than 4 years. This is a simple blood test. The Mayo Clinic notes that B12 deficiency in older adults is often missed because the symptoms overlap with normal aging. Tingling feet, slight memory changes, fatigue. If your B12 is low, replacing it is straightforward. But no one knows it's low until someone checks. Say to your doctor, "I've been on metformin for X years. Should we check my B12? That's the sentence. Step 2, ask whether your current medications still match your kidney numbers. Your kidneys change with age. That's not a scare. That's biology. The eGFR is a number on your standard blood panel that tells your doctor how well your kidneys are filtering. Metformin dosing depends on it. Some medications need to be lowered or paused if kidney function drops. Say, "Can we look at my eGFR trend over the past 2 years?" Doctors love that question. It shows you're paying attention. Step 3, and this is the one that surprises people. Ask about de-intensification. If your A1C has been running low, say under 6.5, and you're over 70, current guidelines from the American Diabetes Association's 2023 standards actually allow for a slightly higher A1C target in older adults with multiple health conditions. Sometimes 7.5 is fine, sometimes even 8. Because chasing a young person's A1C in an older body can cause more lows, more falls, and more harm than the higher number would. You are not failing if your target moves. You're being treated like the individual you are. Step 4, know your hypoglycemia signs and know them cold. Low blood sugar in a senior often doesn't feel like the classic shaky, sweaty picture in the pamphlet. It can feel like sudden irritability, a wave of confusion, slurred words, a stumble. If you're on Glipizide or insulin, keep glucose tablets within reach. Bedside, kitchen, car, purse. Tell one family member the signs, not to scare them, to equip them. If you have a parent or a spouse or a friend on these medications, this next part is worth 60 seconds of their time. Send them this video. It might save a fall. Step 5, track patterns, not just numbers. Get a simple notebook, not an app. A notebook, because you'll actually use it. Write down the time, the number, and one word about how you feel. Foggy, steady, shaky, fine. Do it for 2 weeks before your next appointment. Bring it. That single notebook will tell your doctor more than 100 finger sticks in isolation. Here's the shareability moment I want you to hold on to. Your A1C is a 3-month average, and an average can hide 100 bad moments. Read that twice. That's the sentence that changes how you think about your care. Now let me bring back an illustrative composite. Picture a man I'll call Frank. Composite, not a real single patient. Frank is 74, retired mechanic, still fixes his neighbor's lawnmowers for the fun of it. He's been on insulin for 4 years. His A1C is 6.4. His doctor was pleased, but Frank started falling. Twice in 6 months. His daughter noticed his glucose meter had readings in the 50s 3 mornings that week. Frank thought that was normal. At Frank's next appointment, his daughter came in with a 2-week notebook. She said, "Look at these mornings." The doctor adjusted the insulin, not dramatically. A small reduction. The falls stopped. His A1C ticked up to 6.9, and Frank felt steadier than he had in a year. The notebook did that. Not a new drug, not a new gadget. A $3 notebook and one honest conversation. Now I want to answer the question I know is in your head. Doctor, if my numbers are good, why should I rock the boat? Here's the honest answer. Because good on paper and good for your life aren't always the same thing. A perfect A1C that comes with weekly lows, foggy afternoons, and one fall a year isn't the same as a slightly higher A1C with steady days and safe nights. Ask your doctor which one your current plan is actually producing. Let me name the sources one more time because you deserve to know where this comes from. The American Diabetes Association publishes its standards of care every year, most recently in 2023, and it's freely available online. The American Geriatric Society publishes the Beers criteria, updated in 2023, which flags medications that need extra care in older adults. The Mayo Clinic and the Cleveland Clinic both publish patient-facing summaries on metformin and B12. And the 2019 consensus report from the American Diabetes Association and the European Association for the Study of Diabetes introduced the framework of de-intensification for older adults. Those are real. You can look them up tonight. Bring the printouts to your next visit if you want. Now, red flags. There are situations where you don't wait until your next appointment. You call today, not next week. Today. If you have repeated blood sugar readings under 70, especially in the morning or overnight. If you've had a fall you can't fully explain. If you have new or worsening numbness or tingling in your feet. If you have severe belly pain that won't quit or persistent vomiting. If a family member says, you didn't seem like yourself yesterday, and you can't remember why. These are outside the scope of a video like this. They need direct evaluation. Let me run through the core points quickly. 1. Your A1C is an average, and an average can hide a lot. Ask about time and range. 2. If you've been on metformin more than 4 years, ask about vitamin B12. 3. If you're on glipizide or insulin and you're over 65, ask about hypoglycemia risk and ask about de-intensification. 4. Track patterns in a notebook for 2 weeks before your next appointment. 5. Bring one family member into the loop so they know the signs of a low. Here's the whole message in one sentence. Your medication plan should fit the life you're living now, not the body you had 10 years ago. Before I let you go, there's one thing I still haven't told you. There's a specific class of newer medications, GLP-1 agonists, the ones you may have heard about in the news, that's changing the conversation for a lot of older adults with type 2 diabetes. That's next week's video. Whether they're right for a 70-year-old body is a conversation worth having, and I'll walk you through what the current research actually says. If this helped you see something new, subscribe. In the comments, I'd love to hear. What's one question about your diabetes medication you wish your doctor had more time to answer? I read everyone. Take good care of yourselves. I'll see you next week. This video is for general educational and informational purposes only. It is not medical advice and does not create a doctor-patient relationship. Please always consult your own qualified healthcare provider for diagnosis and treatment. Illustrative scenarios in this video are composites. All identifying details have been changed to protect privacy, Any resemblance to a specific individual is unintentional. Portions of this video use AI-assisted voiceover and visuals.